Today, I want to take the opportunity to welcome Mel Wilcox from the University of Alabama, where he's professor of medicine and surgery, pediatrics, and is the division director at UAB of gastroenterology and hepatology. And actually, Mel is, for him, this is a homecoming. Mel did his training at the University of Alabama, and then he finished and did a GI fellowship at the University of California, San Francisco, where he met James Boyer. And as many of you know, Tom Boyer was the division director of the division in the 1990s, and he recruited Mel here. And the place that Mel wanted to work was not at Emory University Hospital, but he made it clear he wanted to work at Grady. And so Tom made him the chief of GI then. And if you look at Mel's CV, it really is a tour de force of every aspect of digestive health. He has 300 publications, 70 book chapters, 4 books he's written. It's an amazing translational investigator. He was with us for 5 years as an assistant professor, and then he went to the University of Alabama at Birmingham, where he rose the ranks, and also during his time as a full-time faculty member, I note that he also obtained an MPH. He certainly put his MPH to work with some very extensively funded programs by federal and private foundations, and has been a real leader in the University of Alabama Birmingham GI division. Is one of the best in the country, in no small part to Mel's hard work there. He's a luminary in many of our societies, and I think I counted that he's a peer reviewer at one point in his career of 150 journals to date. So he's a very well thought leader. And interestingly, just when he was here at Emory, as he told us yesterday in our clinical conference, that when he came to Emory, of course, the AIDS epidemic, which many of the people in the room now don't really have an appreciation for the devastation of the variety of illnesses, but particularly the GI tract and liver, which were, when we were training, an amazing aspect of what we saw in gastroenterology. And as Mel said, other than GI bleeding, which still goes on at Grady, the major thrust of his interest became infectious disease as it was related to the GI tract. So Mel really is I think, coming from San Francisco and then working here, has published an immense amount of material on the natural history of GI diseases related to AIDS, which cannot be understated today. Mel gave a great talk to us yesterday about idiopathic pancreatitis, and he's going to talk to us today in a general sense about the pancreas. I think for myself as a hepatologist, I still don't know as much about the pancreas. It was an enigmatic organ during my fellowship, and it's kind of a hard organ for many of us to understand what to do when patients have problems. It's not very easy, and yet it's a very common problem. So we look forward to Mel's talk today. Bad pancreatitis is bad, and let's give him a nice welcome. Thank you for coming, Mel.
Thank you. It's a privilege to be here. I appreciate that very nice introduction. As Frank said, when I left San Francisco, I wanted to come to Grady, and it was a real privilege. I've got a picture of Grady in my office. I look at it almost daily. It was just so much fun for me. It was a privilege to take care of the patients, and for somebody who wanted to do clinical research, it was like a kid in a candy shop. I mean, the opportunities and things you can do were really immense, and it was a real blast, and I treasured all the time that I had there. As I mentioned yesterday, if a lot of my work was in HIV, and once the medicines came out, it in some ways put me out of business. So what else could I do to keep myself occupied? So I'd always been interested in pancreatic disease, and there was a real need for pancreatic research, clinical research, and for clinical pancreatology at UAB. So I kind of gravitated to that, and over the last decade, although I've still been interested in HIV more from a historical perspective, I've kind of gravitated to pancreatic disease and got involved in some societies and other things. So I've kind of made that my new home, and it's been a lot of fun. I guess for the young folks, it's kind of the lesson that you can learn is although I was in HIV, you can really adapt clinical research to any field. So I've kind of adapted my clinical research interest to pancreatic disease. And what I was going to talk about today, yesterday I talked about idiopathic pancreatitis, but this is something we're seeing more and more of, particularly at a tertiary quaternary care center, is really the bad pancreatitis. And so a couple of my comments are more general for a medical audience, but we'll talk a little bit about what I call bad pancreatitis. And I use this picture, just that was the tornado that came through the Birmingham surrounding area about 6, 8, 10 years ago, and this is kind of the devastation that was left. So this is kind of what I use in as example of the devastation of somebody that has bad pancreatitis, the mess that we have to clean up afterwards. So since it's a grand rounds, let me just give a brief presentation. I'll kind of summarize this case. This was a morbidly obese guy that I saw 2 years ago, acute onset of severe pain. It was basically acute pancreatitis. Lactic acid was up, white count was up, hematocrit was up, which is an important point. He was jaundiced, his liver test abnormal, really abnormal CT scan, ultrasound showed gallstones. So not surprising this guy had gallstone pancreatitis. He went to the general medical floor. Our GI service was capped. Went to the medical floor, got a lot of fluid, but not much urine output. We were concerned the guy might have cholangitis, so we rushed him over and did an emergent EUS, put him on the ventilator to do that, but he didn't have any bile duct stone, went back to the ICU. And as you can see here, over the next 3 months, he was readmitted back from the floor, back to the ICU on numerous occasions. Here are the complications this fellow had: pulmonary thromboembolism, colonic fistula, renal failure, gluteal abscess. He had several endoscopic necrosectomies, pigtail catheters. He was in the hospital for 3 months and then went to rehab for 3 weeks. And since discharge last year, he's been admitted a number of times for recurrent abdominal pain and for recurrent gluteal abscess. He even had to undergo, ultimately, cholecystectomy for acute biliary sepsis, presumably from the gallbladder. In the last sentence, it says, since his initial admission, he has undergone 18 CT scans, 3 IR drain placement, 2 chest CTs, 4 abdominal ultrasounds, BE, and 2 MRIs. I got them to look up his medical bill just for the 3 months, and it was $1.5 million. So this is a classic case of a bad pancreatitis. People in the hospital for months, really a devastating illness. We'll talk a little bit about that today, but this is really not an unusual case for somebody that really has bad pancreatitis. So some of the objectives of my talk are listed here, and I have no disclosures. I think all of us know the causes of acute pancreatitis. I would just, at the bottom, you can see here idiopathic 10 to 20%, and really anything on this list can cause bad pancreatitis. It's not necessarily relegated to just alcohol or gallstones, but any of these can cause severe pancreatitis. For the internist and audience, I see a number of patients that are actually mislabeled as acute pancreatitis. And just as a reminder, to have pancreatitis, you need 2 out of the 3 of the following: a compatible clinical picture, a serum amylase or lipase that's greater than 3 times the upper limit of normal, and or an abnormal CT scan. So if you have somebody that amylase is 210 and your upper limit is 200, that's not acute pancreatitis, and they present with an earache. So they shouldn't be labeled as acute pancreatitis. You need 2 or 3 of the following. So I think that's very, very important, because you don't want to mislabel patients with acute pancreatitis. One of the things that's come out recently in 2013 was an update of the nomenclature that's used for radiographs, particularly CT scans, and I wanted to briefly review that with you, since that's such a huge part of what we do in GI, managing these patients, is looking at these fluid collections, looking at the pancreas. How would we define that? And these are the new terminology that were used. Many of you in the room might remember the word phlegmon. You don't see the word phlegmon on this list. So it's an acute interstitial pancreatitis down to pancreatic pseudocyst. We'll look at a couple of examples. So this is acute interstitial pancreas. As we see here, the pancreas is a little bit big, a little bit boggy, not really any fluid around it. This is called acute interstitial pancreatitis, generally a mild course. Acute pancreatic fluid collection, you can see the fluid collections here around the pancreas. This is a contrasted study. As you can see, contrast in the aorta, and the pancreas lights up here completely. So this is an acute pancreatic fluid collection. No, it's not a pseudocyst. It's an acute pancreatic fluid collection. This is like our patient admitted today in June, and you can see over 4 months the patient has severe pancreatitis. He has acute necrotic collection, organized necrosis, and then you can see at the very end, 4 months later, this is really all dead pancreatic tissue with just a little bit of pancreas floating around in this necrotic collection. We can also see extrapancreatic necrosis, as you see here, We see all this necrosis here above the pancreas. There has been some necrosis of the pancreas and all this underneath the pancreas. So this is pancreatic and peripancreatic necrosis, which has a little bit different natural history. The importance of necrosis was identified by a radiologist, Balthazar, at York, a number of years ago. And you can see on the left patients that did not have any necrosis with a contrast-enhanced CT scan. Their morbidity and mortality was very low as compared to patients who did have pancreatic necrosis. The role of microlithiasis has recently been further investigated, and here's a typical slide that you might see. If in a patient with acute biliary pancreatitis, you aspirated bile from the duodenum after you stimulated the gallbladder and looked at it under the microscope. We now know that you can oftentimes see this on a routine abdominal radiograph, and most radiologists now will say sludge in the gallbladder. And for the internist in the crowd, microlithiasis is the same thing as gallstones when you're thinking about acute biliary pancreatitis. It has the same implications. Sometimes you don't see this microlithiasis on a routine abdominal ultrasound, but as shown here, it's very well seen on endoscopic ultrasonography, which we use very commonly in patients with unexplained pancreatitis. You see all these crystals here in patients with microlithiasis, which is important to identify as cholecystectomy as curative. This is just one of numerous studies looking at prognostic scores to evaluate how severe somebody's pancreatitis is. And this is really the holy grail of pancreatology. That is, can you come up with some scale to determine if a patient's going to have a bad outcome? This is a nice study, summary study in the annals recently looking at all these scoring systems. On the left, as you can see here, Apache 2. Many of our house staff like using the BICEP score on down the list. But if you look at the sensitivity and specificity, these are all pretty good, but not perfect. And I think we really don't have the perfect scoring system to try to determine if somebody's going to have a bad outcome. Why are we so interested in coming up with these scoring systems? Primarily for clinical research. So I know that my severity of pancreatitis is the same as severity of pancreatitis when we're doing a clinical trial, for example. But I think a good physician's assessment is probably as good as any of these scores in determining how bad somebody's going to do. I would call your attention to two very important predictors for a poor outcome are the following: organ failure and infected pancreatic necrosis. And we'll talk about infected necrosis a little bit later, but as the last bullet says, the relative risk of mortality doubles when organ failure and infected necrosis are both present. Many of these patients may have a mortality rate of up to 50%. So what about therapy? Are there any things that we can do early on to potentially lessen the course? Or if the patient's going to have a poor outcome, is there anything we can do during the course to actually improve their outcome? So is there anything new? I can remember one of my hepatologists who made rounds for me one weekend. He saw me on Monday. He said, "Mel, I made rounds this weekend to see all your pancreatitis patients. All we were doing is giving them intravenous fluids and Demerol. Haven't you all come up with anything new?" Well, yes, we have come up with a few things new, but it's not this Chinese herbal decoction as listed here. So yes, hopefully by the end of the talk, you'll see we have made some progress. What about the types of fluids? And this is something you would do when the person is first seen in the emergency department, or you pick them up in the house staff team. How much fluid should we be giving these patients? Well, it's listed as probably 250 to 500 cc's per hour for the initial 24-hour period, which is probably the most important time if you want to give these patients fluid. Some studies, however, suggest that overhydration actually worsens the outcome, so I would try to follow the recommendations. How do you know when the person really is dry? Elevated BUN, elevated hematocrit, as we saw in our patient representing third spacing might be an important clue. What fluid should you give? The amount of data is not that great, but there's some consensus now, at least by pancreatologists, that maybe you should be using lactated ringers. What about the role of nutrition? We've heard a lot about nutrition and how you should provide it in patients with severe pancreatitis, and just a couple of important points is listed here. We probably don't need to be very aggressive in the first 72 hours. There was some discussion in the past. You need to get a jejunal feeding tube in, start feeding them early. Probably we can wait till after 3 days to see which way the patient goes and decide at that point. I'll show you some data that enteral nutrition actually decreases total infection rate, and that is something that I would strongly recommend. You need to avoid TPN. We still see people who get TPN with severe pancreatitis. That's not the way to go. Enteral nutrition is the way to go. How often do we have patients who cannot tolerate oral intake? Well, as shown in this meta-analysis, it's actually pretty common, maybe 20% or so. And which 20% are going to have the problem with eating? Well, as you might suspect, if you look down this list, it's basically the patients with bad pancreatitis, those who have necrosis, those who have fluid collection. So when you see one of these patients with really severe pancreatitis and they can't eat, then that's going to be a clue that we need to start some kind of enteral nutrition relatively early. Again, another meta-analysis just demonstrating that enteral nutrition actually decreases the rate of infectious complications in patients with severe pancreatitis. So TPN is a no. Enteral nutrition, putting a feeding tube past the pylorus is the way to go. The patients can get the nutrition, they generally tolerate it, and it seems to decrease the total infectious complications. So this is just a summary of one of our clinical societies guidelines, really summarizing what I've told you. TPN, we don't use TPN if you try to give the patient something orally. If they can't tolerate it orally, that's when you go to a Dobhoff tube, generally placed past the pylorus. What about the role of antibiotics? The pendulum here has swung back and forth over the years. About 5 years or so, there was a recommendation if a patient is going to have severe pancreatitis, you need to give them empiric antibiotics. Well, that's actually out of favor now. We know that patients who have severe pancreatitis oftentimes will get a fever. So most of these patients who have severe pancreatitis are going to get a fever. The house staff are going to get their cultures. House staff will put them on antibiotics, so they're going to get on antibiotics anyway. But if the culture data doesn't come back positive, then I would recommend stopping the antibiotics. We'll talk a little bit about endoscopic treatment. So again, these are our ACG guidelines, basically summarizing what I've said. Empiric antibiotics, no. If the patient develops signs of infection, then antibiotics are appropriate, and then wait on your cultures. If you think a patient has infected necrosis, some of these patients may get through the course without any significant endoscopic therapy with antibiotics alone. In the old days, the teaching was that if you developed infected necrosis, you're going to have some type of surgical debridement. That's not necessarily the case anymore, given the efficacy of some of our antibiotics. So we talked a little bit about complication. Early on, I think organ failure is the most important one that we'll see. Midpoint of their course, a month or two into it, they can get infected necrosis, colonic ischemia, as our patient did, venous thrombosis, and pulmonary embolism. On the right-hand part of the slide, I've listed some of the late complications that you'll see, and we'll go over some of these because they actually are fairly common in patients who have severe pancreatitis. So why do these patients get organ failure to begin with? This is a nice, summary slide of all the evil humors that are going on in patients who have severe acute pancreatitis that are likely resulting in the pulmonary failure they have, in the renal failure that they have. And these are patients, again, who have pretty significant pancreatitis, and I already mentioned that organ failure is a marker of a poor outcome. Some of the therapies, although ineffective, have been directed at some of these interleukins, TNF, et cetera, in an attempt to try to decrease the severity of pancreatitis, but we're still a long way from trying to dampen this inflammatory response and thus lessen the severity of the acute pancreatitis. So how would you handle this guy? Severe pancreatitis, develops abdominal fullness here on this axial scan. He's got a little bit of his pancreatic head left. All this is just necrotic fluid. On the coronal image, you can see it's really an impressive amount of necrotic material, essentially filling the entire abdomen. In the old days, you'd have to do this, where you fillet them from the chest all the way down, open them up, and try to clean them out. This was associated with a very high mortality, and generally we try not to do that today. So in a case like I just showed you, how would we try to manage this organized necrosis, or if you thought it was infected, this infected necrosis? We still rely on our surgeons who help us out very much. This is a patient of mine who had this large collection here, had a pretty significant attack of pancreatitis. We really couldn't approach this with some of our endoscopic tools, as I'll mention briefly. Relatively small incision. We see this very thick wall and all this necrotic material removed. He was in the hospital for less than a week and did actually quite well. This patient failed endoscopic therapy. Here on the top you see these drains and stents that were placed in this necrotic collection. Didn't get better, still was febrile, went to surgery, did a cyst gastrostomy, took a lot of this material out. You see the scar here is really not too bad and a few drains left in. So I think the surgical therapy for these patients has improved significantly than in the past, where the mortality was very, very high. But what many of us are doing now is endoscopic therapy. Many of these collections, given the location of the pancreas, is right behind the stomach, and now we can do endoscopic therapy instead of surgical therapy, so-called endoscopic necrosectomy. So here, for example, we see the stomach. The necrotic collection is going to be behind the stomach. You can put a number of stents through the stomach in these collections to help drain, and you may even need to put a percutaneous drain into the collection. So the patient is not requiring surgery. All this can be done endoscopically. So for example, this patient who presented, he was a transfer with severe abdominal pain and some fever. We see this large necrotic collection here. First, a percutaneous drain was placed. He still remained febrile. We see now some stents that were placed in this collection, and within 72 hours, he has improved significantly. Defervesced, significant abdominal pain is now essentially resolved. So somewhat of a combined percutaneous endoscopic approach really can be curative for some of these patients rather than surgery. Some of the ability to do this has depended on the technologies that are available to us. And there's a new short metallic stent with these phalanges on it that can be placed in the cyst wall with nice apposition to the gastric wall. And that was placed here. We see all this necrotic collection. You can actually drive your endoscope into this necrotic collection and do some debridement. Here's just one small study of 124 patients showing technically 100% success, and in many of the patients resolved after this endoscopic necrosectomy in a safe fashion. So a lot of what we do now is endoscopic therapy for these collections rather than surgery. Some patients may be discharged from the hospital or actually be in the hospital doing quite well and all of a sudden develop abdominal pain and fever. And this is what we would dread in this situation. This is a patient who's this necrotic collection. Now we see all this air in this collection. This patient now has developed an abscess. You can treat these sometimes endoscopically, sometimes they have to go to surgery. Just wanted to raise this issue because you may read about the so-called disconnected duct syndrome. And this is important for us as endoscopists and gastroenterologists, how to manage these patients long-term when we put these drains in. We can diagnose this oftentimes by the CT scan or MRCP, and let me just give you a couple of examples. So here's a patient who has this large collection here at the neck and head of the pancreas. We don't really see much pancreatic duct upstream. One might predict that this has taken out the whole portion of the pancreas, including the duct in this area. Here we see an MRI. This might look like just fluid, but this MRI of the collection shows all this internal debris demonstrating that it is actually a necrotic collection. But let's focus now on the duct. Here we see a little bit of the pancreatic duct here going into this collection. Here's some more of the pancreatic duct going into this collection and just demonstrating that this is a disconnected duct. Here, if you inject the pancreatic duct here, it stops, and the contrast then goes into this collection. So basically, one portion of the pancreas, if it's still alive, is completely disconnected from the head of the pancreas. So what's going to happen to that patient long term? Well, you have these stents in the collection. If you remove the stents and there's still a disconnection between the two parts of the pancreas, then the patient's going to reform this collection in a fluid collection. So generally, when we think somebody has this disconnected duct syndrome, which is actually very common, we tend just to leave these stents in long term, because if you pull them out, they're going to recollect. So this patient, for example, you could predict that this patient is going to have the disconnected duct syndrome. He's got all this ascites, but look, there's all this necrosis from the head of the pancreas toward the tail. So this patient will have a viable tail and a viable head of the gland, and all the gland in between is essentially gone. So this is important for us as endoscopists, thinking about how to manage these patients long term with these drains, or even with surgery, which was done in the past. Or you might see this patient who was discharged from the hospital doing quite well, but noted he had a rising, which is what we say in Alabama. He had a rising on the left side of his abdomen. As you can see here in clinic, this bulge, not particularly painful, just kind of a little bit disfiguring to him. Here's a CT scan. This is about 2 months after his attack. This would be now a pseudocyst. If you did an MRI and you saw no echoes in here, or an ultrasound, this is pure fluid, and these are drained very easily endoscopically. This would be right behind the stomach, as you see here. You put a drain from the gastric wall into this collection, it would drain very nicely. So most of us now are draining these classic pseudocysts endoscopically if there's a nice apposition to the gastric wall. I showed a similar scan earlier on in a patient who had infection, but some of these patients with severe pancreatitis, this necrotic material will kind of find its way out of the pancreatic bed. So this patient came into clinic, was actually doing quite well, and got a follow-up CT from the surgeon, and I was called urgently by the CT scanner, thought the patient may have a pancreatic abscess because you see all this air inside this area of necrosis, but he was doing perfectly well. He actually had some bleeding at the same time, and we did an upper endoscopy, and this just shows this necrotic material exuding from this hole in the second duodenum, which is basically how this air got into this fluid collection. This necrotic collection basically ate itself into the duodenum. Here you can see here we're actually driving into the collection, this necrotic collection in the second duodenum. I mentioned one of the other complications we occasionally see is colonic ischemia, or one of the necrotic material can eat itself into the colon. How do these patients present? They could present with pancreatic sepsis, or more commonly with a lower GI bleed. So the classic would be somebody who's still in the ICU after 2 months, severe pancreatitis that develops lower GI bleeding, that develops this collection from the pancreatic bed into the colon, as you see here. Pancreatic pseudoaneurysm is something else we see not infrequently, and it would look like this big contrast bulge here in the head or tail of the pancreas. These can be life-threatening, usually treated very successfully with interventional radiology and coils. This patient would present with severe upper GI bleeding months after an attack of acute severe pancreatitis. We also see patients who develop chronic pancreatitis and biliary strictures, as you see here. This is irregularity of the pancreatic duct, and this smooth, long stricture here in a patient who had severe pancreatitis and a bile duct stricture. Oftentimes we can treat these endoscopically, but occasionally surgery is required. Just as a reminder that in patients who have mild pancreatitis, if you think it's a biliary source, it's very important to send the patient probably for cholecystectomy before the patient leaves the hospital. This is a randomized study published in The Lancet last year that demonstrates that in patients who have mild pancreatitis, presumed biliary, that you need to get the gallbladder removed before they go home. Recurrent pancreatitis in the interval cholecystectomy, that means let them go home. was 9% versus 2% in the patient who had the same admission the same time. And one of the problems here is the patient comes back with acute pancreatitis. It may be severe. So it's incumbent, I think, upon us to make sure that the patient gets a laparoscopic cholecystectomy for mild pancreatitis. Generally, the surgeons are aware of this data, and it's in their recommendations as well. So what about long-term? I showed some of the medium-term complications that these patients have. Diabetes is not infrequent. It happens a little bit more commonly than exocrine insufficiency. Some of these patients may actually develop chronic pancreatitis, meaning chronic abdominal pain requiring narcotics, frequent hospitalizations. They can also have recurrent pancreatitis from this abnormal pancreas that's still in the abdomen. And the last one I put down is PTSD. So he said, how does that relate to severe pancreatitis? I've had a number of patients that I've learned from that tell me that once you have a severe attack, every time you get some minor GI upset, they start panicking that here it comes again. So it's almost to me like a PTSD, and these patients have to live with this. So to conclude, I think significant progress really has been made in our management of acute pancreatitis and severe pancreatitis. We talked a little bit about nutrition, which I think is important. Antibiotics, we talked about that, and some of the more minimally invasive surgery, both traditional surgery as well as endoscopic surgery. Long-term complications are still a significant issue and something that we have to be vigilant for, and these patients can develop significant long-term morbidity, some of which I've mentioned it to you. So I'll stop here and address any questions that you have, and appreciate the opportunity to come back.
Okay, we're going to open it up for questions. I'll start off with one. If you could just briefly back to the nutritional aspects of it. You said TPN, absolutely no. Maybe you could tell us a little bit more about why and rationale for avoiding TPN in these patients.
Good. Very good question. So if the patient, you think they're able to eat, then even though they have what looks like severe pancreatitis, all this inflammation, but eating doesn't cause significant pain or vomiting, then a low-fat diet is appropriate. Many of these patients are not going to be able to tolerate that. So if you wanted to use TPN, it's relatively safe, but there are complications, more infectious complications. The cost is higher. But I think what the data that's available would suggest is that if you're feeding the gut, that's actually making the gut work normally. It doesn't atrophy, and the hypothesis is that you're less likely to get translocation of bacteria. So that's kind of, I think, the philosophy or the hypothesis of why there's less infectious complications, particularly this infected necrosis, if you feed the gut. So, yeah, TPN may be a little bit easier. Nobody wants these tubes in their nose, but I think that's the hypothesis, that you're feeding the gut's working, and you're going to get less translocation of bacteria, in contrast to atrophy, which you'd get with TPN. So that's the rationale. Good question.
Do we have some other questions from the audience? Wendy?
I haven't seen these gastric stents that you were describing. So these are stents placed endoscopically from stomach to collection.
Correct.
So so it's almost marsupializing the collection. So I guess my question is, how do you, once you've drained that, I assume you don't pull these back out, so how do you keep them from developing into an abscess there? Is it just a walled off area given all the inflammation that's happened?
The answer is yes. You're able to see these in the old days, when this technique was first kind of described. We did this blindly. So you had one of these big collections of essentially facing the stomach endoscopically. You're just like putting a needle blindly in there. Well, sometimes that worked, sometimes it didn't work too good. But under endoscopic ultrasound, you can actually see the collection. You turn on the Doppler, you can see if there's any blood vessels in the way. As you know, many of these patients might get splenic vein thrombosis, gastric varices, so you can make sure those aren't in the way. Stick a needle actually in the collection, and you're looking at all this real time. Put a wire in it, stretch it, cut it, whatever, and then you put the stent in. You generally try to leave it until it completely collapses, but if you think you have this disconnected duct, you basically have this small little collection. You don't really get infection of the whole bed. Now, if you put one of these in and there was no infection at that time, just pain. If there's not adequate drainage, then you can convert an uninfected to an infected collection, which is not a good thing. So you try to put multiple drains in. With these larger metal stents, the drainage is much better, and you're even less likely to get an infection.
Mel, I wanted, since this is medical grand rounds, if you could discuss with us how you think people should be managing pain, since pain management has come under fire, as you know, and it's oftentimes very difficult since the pain of pancreatitis is really exquisite. People are particularly seen first by an ER doc or a house officer. I wonder if you could go over that.
Yeah, that's really a difficult question. I'm not sure if I know what the right management is. People have talked about not using morphine because it'll cause spasm of the sphincter. I don't know if that's true or not true. The house staff tends to use a lot of Dilaudid, which I think is pretty potent. I've never actually gotten any Dilaudid myself, but I think patients tend to like that. But hopefully you can the problem really is transitioning them from something IV to something oral on a more long-term basis. Maybe we try to put a fentanyl patch, try to antidepressant for chronic pain, but that's sometimes the real challenge is converting them from something IV to something oral. Some patients, particularly the older ones, don't like to get any pain medicine because, quote, they don't want to get hooked. So when a patient tells me that, you know they're not going to get hooked because they're scared of the medicine. There's some of the more younger ones, maybe they've had exposure to narcotics, and you almost can't convert them from IV to PO. Those are the more difficult ones. So I don't have any real great thing to tell you other than try to add potentially a fentanyl patch to decrease the amount of IV requirements, antidepressants, those kind of things. But it's a difficult area.
So we have a question from Grady, and the question is for patients who have biliary sludge on ultrasound and biliary symptoms, do you recommend cholecystectomy?
Yes, I guess my rule of thumb is biliary sludge is the same as stones as far as acute pancreatitis. So when you see that on an ultrasound and they comment upon it, then laparoscopic cholecystectomy is appropriate.
And then one more, they're all coming through me for some reason. If indomethacin has a role in post-ERCP pancreatitis, can we use it in acute pancreatitis?
I think you can use it, but I don't know that there's any data that it does anything. I think it may stop part of that cascade, but as many of the seasoned clinicians in the room know, once the bad pancreatitis is out of the bag, it's out of the bag. And there's really almost nothing you can do to put it back in other than waiting to prevent the complications. That's kind of the way I see it. So some of the medicines that have been tried targeted some of these specific areas like TNF, et cetera, to see if you could actually dampen it, potentially like indomethacin, but doesn't seem to be.
Okay, well, if there are no more questions, we'd like to thank our speaker again. Mel, thanks for a great talk. Really appreciate it.